I think we'll move on. Dr. Abhinav has joined. So Abhinav is an SCPGI product again. He did his DM from SCPGI, and he is currently the Director of Gastroenterology Services at CK Birla Hospital in Jaipur. Abhinav is going to talk to us about endoscopic diagnosis of abdominal tuberculosis. Abhinav, if you could finish at about 8:55, because we usually close the masterclass at 9. Thank you.
Yes, sir. The topic given is to me is endoscopic diagnosis of abdominal tuberculosis, particularly intestinal tuberculosis, because abdominal tuberculosis is a vast topic. This already must have been discussed that 20% of all cases of tuberculosis are extrapulmonary, out of which around 13% are abdominal tuberculosis. Varied presentation, peritonitis, lymphadenopathy, intestinal tuberculosis, and sorted organ like pancreas. Now, this is the basically hierarchical approach of diagnosis. We rarely get confirmed diagnosis because positive culture and positive AFB we rarely see. So we have to resort to either possible or probable diagnosis. And when we call it is definitive tuberculosis is when we see growth of mycobacterium tuberculosis or histological demonstration of typical AFB or necrotizing granuloma. But the problem is poor sensitivity because yield is low, around 30 to 50% sensitivity we can get at the most. So most of the time we have to make presumptive diagnosis based on clinical, histological, pathological, and radiological criteria. And we are more sure when there is an unequivocal response to ATT over 6 months. And what is the role of colonoscopy? Endoscopy is basically not in peritoneal type, but generally in gastrointestinal type of tuberculosis. The role of endoscopy is to characterize the lesion, to make a presumptive diagnosis, and then to obtain a tissue. And these are the Indian series. What are the most commonly involved region in intestinal tuberculosis, particularly, and we all know it is ileocecal region, terminal ileum, and ascending colon, which is more frequently involved than other regions. Now, the endoscopic findings depend on the stage of disease when we pick them up. And in early stages, basically lesions are very mild. They are basically can be easily missed, like mild loss of vascular pattern or just an erythema or maybe superficial ulceration. So we have to be very careful while doing endoscopy in patients with chronic symptoms, particularly when we are suspecting tuberculosis, and we should biopsy them. And there is a series where even in normal findings, people have picked up tuberculosis if the biopsy is added to the diagnostic endoscopy. But as the disease advances over years and maybe months or over years, the advanced region might come up, which are deep ulcerations, nodularity, and maybe strictures. So these are the basically typical lesions which we see in endoscopy or maybe colonoscopy while doing while doing evaluation of intestinal tuberculosis. Terminal superficial ulcers, or contracted cecum, narrow deformed IC valve, multiple ulcerations on IC valve, particularly cecum ascending colon, gaping IC valve with multiple ulcerations on IC valve, cecum and ascending colon. These are the kind of lesions we see depending on the stage of the disease. Here again, we can see ulcerated IC valve, nodularity and ulceration around a patulous IC valve, fixed open IC valve, and circumferential ulceration. These are the, and people have tried to even characterize these patterns into different forms of tuberculosis. One of them is ulcerative form, where we see multiple ulcerations, and ulceration usually transverse with surrounded nodularity. Then another variety is hypertrophic form, which may present like mass-like lesion on IC valve with ulceration, and the stricture form, where we have strictures. So these are the most common finding, colonoscopic finding in colorectal tuberculosis. What kind of ulcers we see? Ulcers are usually linear, fissured ulcer. Their orientation is transverse or circumferential, and they are covered with exudate. The surrounding mucosa is usually abnormal with erythema, edema, irregularity, and nodularity. And the most common differential diagnosis when we do endoscopy of these patients is with Crohn's disease. So ulcers in Crohn's disease are linear, serpiginous again, but their orientation is longitudinal. Aphthous ulcer are seen in Crohn's, not in ulcerative colitis, and the peculiarity here is intervening mucosa between the ulcer is usually normal, and there will be skip areas. If added with cobalt stone appearance and anorectal region, then again suspicion of Crohn's becomes high over tuberculosis. So, what is the data on which these findings are based on? This is an analysis of one of the earlier in 2006 published in Endoscopy, colonoscope finding in the differential diagnosis between intestinal tuberculosis and Crohn's disease. 88 patients equally distributed tuberculosis, intestinal tuberculosis, and Crohn's disease. And what they found was that features which were suggestive on colonoscopy, which suggested intestinal tuberculosis, transverse ulcer, patulous IC valve, and involvement of less than 4 segments of colon and scars of pseudopolyp. And if there are aphthous ulcers, cobalt stone appearance, longitudinal ulcers, and anatomic regions, these are the features suggestive of Crohn's disease. And patulous was with surrounding heaped up folds or destroyed IC valve that again goes in favor of tuberculosis. What they further went on to give them a score. Each of these 4 and 4 findings, total 8 findings are there. 4 in favor of tuberculosis, 4 in favor of Crohn's disease. So for Crohn's disease, they give 1 point each for each of these findings, and these points were in positive. And for tuberculosis, they again 1 negative point for each of these findings. And when they compare mean score, Crohn's disease patients had total positive score. Mean was 1.61. While ileocecal tuberculosis had a negative score, is minus 1.95. And if we apply these features, the accuracy of diagnosis in that study was 87.5%, which is quite high. So based on endoscopic feature, we can presumptively make a diagnosis or make up our mind whether this is falling towards Crohn's disease or towards tuberculosis. Now, this is one of the initial Indian studies, World Journal of Gastroenterology, Dr. Deepa Kamragupurkar from Mumbai. They looked at endoscopic criteria and trying to differentiate Crohn's disease and GI tuberculosis. And they found that deep, linear or serpiginous ulcers and cobblestone appearance were in favor of Crohn's disease, rather than ulcerative colitis. This is another study from AIMS, clinical endoscopic and histological differentiation between Crohn's disease and intestinal tuberculosis. And with respect to intestinal manifestations, features suggestive intestinal tuberculosis was nodularity, while aphthous ulcer, cobblestone, skip area, and linear ulcer, these are suggestive of Crohn's disease as in previous studies. This is a Chinese study, 152 patients. Again, features suggestive of intestinal tuberculosis were ring-like ulcer, means transverse ulcer, or rodent-like ulcer, means deep punched out ulcer, and a fixed open IC valve, and particularly if site is cecum or IC valve. While Crohn's disease was suggested when there was longitudinal ulcers, grid-like ulcers, cobblestone appearance, and nodular hyperplasia, with particular predilection for lactosigma. So based on these features, they tried to differentiate, and this was the result. This is a study from Vellore, 60 patients, equally distributed in intestinal tuberculosis and Crohn's disease. They found features suggestive intestinal tuberculosis, ring-like ulcers, rodent-like ulcer, and fixed open IC valve, similar to the Chinese study. While longitudinal ulcers, skip lesions, and higher number of colonic segment involvement was suggestive of Crohn's disease. So this findings of this study was similar to the Chinese study. Now, what are rodent-like ulcers? These are deep punched out circumscribed ulcers, as seen here in the picture A. Ring-like ulcers are transfer ulcers. These are seen as we can see in panel B. Now, this is a particular finding which is very specific. Fixed open IC valve means the fixity shows scarring, fibrosis, and fixed open IC valve goes in favor of tuberculosis. Now these are the pictures of transverse ulcers and mass-like lesions seen in hypertrophic ulcerative and hypertrophic form of ileocecal tuberculosis. Now these are the typical lesions of Crohn's disease. We can see the ulcer go into longitudinal extent here in both of the pictures. These are aphthous ulceration on the left, which is quite characteristic of Crohn's disease. And if we see internal fistulae, as we see here in the picture on right side, this goes more in favor of Crohn's disease. And this is classical cobblestone appearance in Crohn's disease. Now, these are the individual study. But now this we can go refer to this meta-analysis, which included 12 study, around 1,000 of patients, around 600 of tuberculosis, around 500 Crohn's disease. What they found from this meta-analysis that transverse ulcer and patulous IC valve, these are the features suggestive of intestinal tuberculosis. Sensitivity is not that great, but specificity is quite high. And features suggestive of Crohn's disease or aphthous ulcers, Crohn's disease, skip lesion, and longitudinal ulcers. So again, further confirmation of reaffirmation of findings of previous studies. Now, this is another meta-analysis on which they used Bayesian statistical model for differentiating intestinal tuberculosis from Crohn's disease, published in American Journal of Gastroenterology 2017. Number of study was more as compared to previous meta-analysis. More than 3,000 patients, around 3,700 patients were included. Good sample size. And what they found is that the features there in red, these features favored intestinal tuberculosis, and features which are labeled here in teal blue, they favor Crohn's disease. So transverse ulcers and patulous IC valve goes in favor of tuberculosis, while longitudinal ulcer, aphthous ulcer, cobblestone appearance, skip lesions, they go in favor of Crohn's disease. So, other than looking going by appearance, what else we can do? We can take a biopsy. So, how much is the number of biopsies we should take? 3, 4, 5, 6, 7, or 8. So, this is the study from India, from Mumbai group, 182 patients. They took biopsy and performed culture on MGI, which is one of the advanced culture method. What they saw from the study that taking 8 biopsy instead of 4 biopsy increased positivity of culture from 40 to 52%. So from the study, the author concluded that we should take 8 biopsy pieces if we suspect tuberculosis and if we intend to do culture for mycobacterium. ICOMR also published a worksheet for diagnosis of tuberculosis, and their recommendation is at least 6 biopsies should be taken in sterile saline for microbiological testing, which includes culture. Now, what is the positivity rate on intestinal tissue? Why advanced culture method? Because culture method, the yield depends on the type of culture method which include. In general, culture method varies from 7 to 79%. Mean is 50%, but advanced culture methods may give more yield. So we should always go for advanced culture method or nucleic acid amplification test or PCR-based test. Now, a word about endoscopic ultrasound. This is done for basically sampling lymph node or sampling submucosal lesions which are missed by endoscopic biopsies. So, what is the diagnostic? This is from SGPGI. A good number of patients, 31 patients were diagnosed with tuberculosis. They did gene expert to diagnose tuberculosis, and their positivity rate of USA FNA and gene expert was 97%. So, these are the lymph node, periportal, subcanine, subperipancreatic, ciliary, paraesophageal lymph node which they sampled, and these are the various test which they did on the FNA aspirates. So gene expert had highest these 97%, cytology 77%, smear didn't do very well, around 39%, and conventional culture fared least around 30%, 13%. So gene experts gave good yield. Now this is my last slide to summarize. The endoscopy plays important role in diagnosis of intestinal tuberculosis. Identification of pattern involvement may give clue to diagnosis. The intestinal tuberculosis patient tend to have transverse ulcer and patullar IC valve confirmed in various studies and meta-analysis. The endoscopy helps in tissue acquisition. The recommendation of a biopsy is at least 6 to 8, more the merrier. And USFNA lymph node, if we are doing, we should go for gene expert to detect mycobacteria. Thank you so much.
So thank you.
Hope I finished on time, sir.
Thank you, Dr. Abhinav, for finishing on time because we were, sir finishes absolutely at 9. We have 2-3 minutes. So one of the important message you have tried to give that FNA we can have a gram, we can have a tissue which can be used for the gene expert, and we can understand that this particular thing might be resistant to the routine ATT. So that point is very, very important. And other than, I think all points has been covered. So we can, Kapoor sir, if you want to say something, or we can ask any other comment by any question by anybody or any other comment, anything we are not seeing in the chat box.
No, not really, but I think endoscopy plays a very important role because now a large part of the GI tract can be accessed endoscopically. Uh, Definitely for biopsy and some areas at least for visualization, and the features which Dr. Abhinav described to a great extent can at least suggest, if not diagnose, that we may be dealing with tuberculosis. Of course, as has been emphasized earlier, the point which Dr. Sitaram mentioned, that in all these cases, a tissue diagnosis, whether of tuberculosis or of some other disease like malignancy, is very important. And there is very little place in very highly selected cases after careful thought of therapeutic trial, which should not delay the treatment of other diseases, especially malignancy, which is a great mimic. So I think we will continue our discussion tomorrow, mainly for management of tuberculosis. And for today, again, on my behalf and Dr. Yadav's behalf, I would like to thank Prakash Saswal, Saurabh Galoda, Pankaj, and Abhinav. Thank you for joining. And Abhinav has contributed earlier to several master classes, and I'm sure we will continue to have him. So with that, I think we will close dot at 9 o'clock. And I kept seeing in between about at a given point in time, more than 30 people were watching live. But as I have been watching earlier, these videos of master classes, which are uploaded on YouTube by Dr. Avinash Tank's technical team in Ahmedabad. Avinash is again a SCPGI fellow. They are watched by a large number of people later, both students and practicing surgeons. So I think the efforts which you all are putting in contributing to these master classes is not going down the drain. It's not a waste. It is being used by students and surgeons. And I feel that even if one student can pass in the exam, or one physician or surgeon can treat a patient properly after a master class, the effort is worth it. So with that, thank you all, and have a good night. And we will close and meet again at 7. Thank you, TD.
Thank you, sir. Good night, sir. Good night.
Thank you. Bye. And thank you, Himanshi and others at Ahmedabad. Thank you.